I think couple of slides are the repetition what the previous two speakers have already said. First of all, we know that it is a synthetic prostaglandin E1 analog. Originally, it was used for gastric ulcers, and then obstetrics, it is used for cervical rightening, labor induction, and PTA. It is safe and cost effective when used appropriately. So, the drug, when taken, it is converted into active form by the liver. Routes are oral, vaginal, sublingual, buccal, and rectal. Onset of action is 8 to 10 minutes for oral, 20 to 30 minutes for vaginal, and half-life is 20 to 40 minutes. It stimulates uterine smooth muscle, increasing the strength and frequency of uterine contractions. In uterine cervix, it also promotes the breakdown of collagen in the connective tissue and a reduction in cervical tonus. So this is a busy slide, but we know we've already mentioned that what dosages are required for which period of gestation, and I'll be repeating them. Indications for third trimester are induction of labor, for cervical ripening, for medical termination in cases of IUFD, for management of intrauterine fetal death, and also for prevention and treatment of PPH. When used for labor induction, it is used when induction is medically indicated with unfavorable cervix. Route is vaginal or oral. Dose is 25 micrograms vaginally every 4 to 6 hours, and it promotes cervical ripening and uterine contraction. This is just a revision that how we know about the Bishop score. So Bishop score, if it is less than 6, then we need more of cervical ripening for the induction to be successful. Bishop score of less than 6 often needs ripening. Misoprostol is more effective than oxytocin alone, and the preferred route is vaginal. Dose is 25 micrograms every 4 to 6 hours as recommended by WHO. It is to be avoided in women with previous uterine scars, so it is not recommended for cases of vaginal birth after cesarean section. IUFD, it is effective for induction post IUFD. 28 to 36 weeks, the dose is 25 to 50 micrograms vaginally every 6 hours. For more than 36 weeks, it is 25 micrograms vaginally every 6 hours. Goal is vaginal delivery with minimal intervention. So, medical termination in third trimester means the delivery in third trimester. Medical termination I should not have been using it. It is used in selective cases like in fetal anomalies or in intrauterine fetal death. It is to be used with Misoprostol, which is given 200 milligrams orally. Then Misoprostol, 100 to 200 micrograms vaginally every 4 to 6 hours. But the patient requires hospitalization. High doses are to be avoided to prevent uterine hyperstimulation. It can be used to augment labor if progress stalls after rupture of membranes and poor cervical dilatation. Cochrane Review 2021 recommends vaginal Misoprostol has higher vaginal delivery rate within 24 hours than dinoprostol with acceptable safety profile. PPH prevention and management, it is used for active management of third stage of labor. 600 to 800 micrograms orally or sublingually if oxytocin is not available. WHO recommends rectal Misoprostol 800 to 1000 micrograms in settings with no injectable uterotonic. Useful in low resource settings in home birth or field settings as it has been included as an essential medicine in A&M kits. Rectal route for ongoing bleeding, and side effects include fever, shivering, and diarrhea. Routes of administration we've already mentioned. Oral, when it is given, it is fast with moderate efficacy. Then vaginally, moderate onset of action because the onset of action is little delayed, but if the action persists for a longer time, it has high efficacy because it helps in ripening of the cervix also. Sublingual route is the fastest with high efficacy for PPH especially. Rectal route is slow onset with moderate efficacy. So for labor induction, 25 micrograms vaginally every 4 to 6 hours. For intrauterine fetal death, for the duration of 28 to 36 weeks, 25 to 50 micrograms vaginally every 6 hours. For termination of pregnancy, 100 to 200 micrograms vaginally every 4 to 6 hours. For PPH, 600 to 800 micrograms orally or rectally as a single dose. The contraindications include serious uterine scar, uterine abnormalities, so higher doses should be avoided in such cases. Hypersensitivity to prostaglandins. If the patient is already in labor, so lesser doses should be used, and one should take care of if fetal distress is there, one should not use in higher doses. Grand multipara, we will need to control the dose. In suspected ectopic pregnancy or confirmed older pregnancy, it should be used with caution. Side effects include uterine tachycystole, uterine rupture, which is a rare but serious problem, nausea, vomiting, diarrhea, fever and chills, and abdominal pain. Monitoring and precautions. Continuous CT monitoring should be done if the fetus is viable and we are inducing for a live pregnancy. Monitor uterine contractions. Avoid high frequent doses. Emergency setup is essential. Obtain informed consent. WHO recommends as an alternative when oxytocin is not available. ACOG also supports use in indicated cases. Emphasize individualized dosing and monitoring. So Misoprostol is versatile and cost effective. It is used for induction, intrauterine fetal death and PCS. Safety is appropriate when used in appropriate dose, route and monitoring. It is vital in low resource settings. So these are the references. Thanks.